Okay, we're going to go ahead and get started. So, good morning, everyone, and thanks for joining us for week 7 of our 12-week ECHO series on health equity and cardiovascular risk. I'm Jim Werner, and I'm filling in for Gautam Rao today as the facilitator. He's away at a meeting, and he'll be back next week. Please remember not to use any protected health information during the case discussions and presentations. Here are some reminders to make use of the chat feature to ask questions or contribute to the discussion at any time. And feel free to unmute and ask questions or make comments during the Q&A following the didactic presentation and during the case discussion. Also, there's some contact information provided here if you have any technology issues or general comments or questions about the series. And here's some general information about Cardio, which is the parent program for our ECHO series. Listed here are the leaders and content experts for this ECHO series. And today's presenters will be Dr. Danette Conklin and Dr. Revital Gorodeski Baskin of Case Western Reserve University. They'll be presenting on the topic of cardiovascular disease risk and menopause. And Dr. Marilee Clemens and I will be the lead discussants today. But of course, all content experts who would like to do so are invited to share their perspectives during the case discussions. We have just one case today to discuss rather than our usual two. Today's case is a really interesting, I think a very challenging case that will be presented by Dr. Austin Fredrickson. And here are the disclosure statements. I don't believe that any of this has changed from previous weeks. And with that introduction, Dr. Conklin and Dr. Gorodeski Baskin, please take it away.
Good morning, and thank you for inviting me to speak today. Our learning objectives for today are to describe the changes in cardiovascular risk among women experiencing menopause, list and describe key elements of a clinical evaluation for menopausal women that are unique to this population, and describe interventions to reduce cardiovascular disease risks of pre- and postmenopausal women. Per the World Health Organization, we've known that obesity prevalence has tripled from the years of 1975 to 2016. And most of the world's population live in countries where overweight and obesity actually killed more people than underweight. That used to be more the case a long time ago. No longer is obesity just a high-income country problem. It's really prevalent across the world. We know that worldwide, hundreds of millions of people are afflicted by heart disease, diabetes, and obesity, and the combination of these three have contributed to a major economic burden that we face in our society. Cardiovascular disease has become the leading cause of morbidity, mortality, and disability in developed countries. Interestingly, when we study the evolution of the human diet, kind of going back in evolution, we see that the fossil evidence shows early human ancestors were interestingly primarily fruit eaters. And then the major shift in the human evolution occurred about 1.8 million years ago with Homo erectus. And these individuals had developed a greater hunting skill capacity. They developed control of fire, and this allowed them to develop or mature their diets. And then eventually there was a shifting into complex agriculture and grain-based foods in the Homo sapiens. And as we see here, in 2023, we've probably gone in the wrong direction. We all recognize this and know that the human evolution has reverted in a direction that we're not so happy about. Now, interestingly, when we're studying kind of the history of nutrition, it really hasn't come into understanding of the food and nutrition and its relationship to disease. Only really it came into association, kind of this realization that food has a relationship with how we develop disease only in the last few hundred years. So kind of going back in time, in 1747, James Lind discovered that eating fruit could prevent scurvy. And this was actually 200 years prior to the isolation of vitamin C. And then over the decades, we developed the understanding of certain vitamins and nutrients and their overall contribution to our health. In the early 1800s, the first scientific report of the benefits of fasting was published. And in the 1920s, the ketogenic diet was described by Dr. Joslin and colleagues, and they published this in the Rockefeller series. They actually encouraged what they diagnosed as diabetics at the time to go on a ketogenic diet, and they even described this as, quote, a starvation diet. Of course, at the time, they didn't understand the detrimental effect to the type 1 diabetic population, but the type 2 diabetic population really benefited from this very strict ketogenic diet. And since the 1970s, there was a distinct shift in nutrition policy to address chronic disease. And we've come to an understanding that ultimately dietary intervention is preventative medicine at its best. Heart disease factors. So we know that about 2,200 adults die daily in the United States due to cardiovascular disease. And obesity increases the risk of cardiovascular disease by twofold. We know that heart disease and stroke risk include factors such as unhealthy diet. Visceral adiposity plays probably one of the most important roles. Physical inactivity and sedentary lifestyle certainly has gotten worse since the COVID pandemic. Tobacco use, harmful use of alcohol. We know that visceral adiposity is the most metabolically active fat in the abdominal cavity, and that this form of fat, this is located in the visceral fat, not the subcutaneous fat, the fat in the abdominal cavity surrounding the intestines, contributes to hypertension, dyslipidemia, cardiovascular disease, type 2 diabetes, fatty liver, even several cancers. Now, the unhealthy nutrition habits that are very prevalent in our society are the added sugars in the processed foods that we eat, excessive salt, refined foods, unhealthy fats. Unfortunately, there's a very low intake of vegetables, fruit, whole grains, fibers, fish, and nuts. These foods tend to have a shorter shelf life, and they tend to be more expensive because they go bad quickly. So all of these combined contribute to the cardiovascular disease risks. The dietary interventions that have been studied extensively to impact cardiovascular disease include the following. Calorie restriction has been shown to be beneficial. Fat restriction specifically is very beneficial. The Mediterranean diet is something I will discuss in a little bit more detail today. The DASH diet is a version of the Mediterranean diet that focuses specifically on low salt intake. The ketogenic diet has a variety of formats. Some can be quite unhealthy, some very healthy. Plant-based diet and intermittent fasting. Due to lack of time, today I will delve into the Mediterranean diet and the plant-based diet. So we know that the Mediterranean diet encourages a high intake of vegetables and whole grain cereals, extra virgin olive oil, fruit, and tree nuts, a moderate intake of fish and poultry and wine, and a very low intake of red meat, specifically dairy, the processed meats, and the sweets. Now, in studying the Mediterranean diet, this was really first discovered in the 1960s, or not discovered, but kind of presented. And it really originated from the then eating habits of the 22 countries that surrounded the Mediterranean Sea. And it really demonstrated a very full, rich diet. So the PREDIMED study was a landmark study, and this was a parallel group multi-center randomized control study out of Spain. And it enrolled over 7,000 patients. These patients were specifically at high risk for cardiovascular disease, but at the time, there was no cardiovascular disease at baseline. They enrolled them for over a span of 4.8 years, and they randomized them either to a Mediterranean diet with extra virgin olive oil group, a Mediterranean diet with mixed nuts, or a control group. They did not specify a total calorie restriction, though. And what they noticed is that there was actually a 30% reduction in the risk of MI, stroke, cardiovascular death, and new onset type 2 diabetes in this particularly high cardiovascular risk group in both the Mediterranean diet categories. And they also demonstrated improved lipoprotein function and increased anti-inflammatory and antioxidant capacities. Now, we know that in the menopausal transition, there's depletion of ovarian follicles, decreased ovarian follicle responsiveness to the pituitary gonadotropins, the FSH and the LH. There's a lowering of the serum levels of ovarian hormones, specifically estrogen and progesterone. And this, all in all, contributes to a variety of negative symptoms. There's vasomotor symptoms, hot flashes, vaginal dryness, osteoporosis eventually can develop, cardiovascular disease, and breast cancer. So the Mediterranean diet in menopause has been studied, and they've documented the severity of the menopausal symptoms have shown to have an inverse relationship with the association with and adherence to the Mediterranean diet. So more adherence to the Mediterranean diet had shown improvement in these menopausal symptoms. They documented that the intake of legumes and extra virgin olive oil was associated with lower severity of these symptoms and psychological symptoms. Part of it could be due to the soy intake. We know that soy is known as a legume, and soy is essentially made up of isoflavins, which is a similar chemical structure resembling estrogens. So dietary phytoestrogens are bioactive compounds with estrogen activity. So the thought is additional soy intake can contribute to some improvement in the menopausal symptoms. Interestingly, I know this is kind of small, but there's been an association of these phytoestrogens with different life stages. So in the premenopausal women, no significant effect of positive or negative effects were really observed. In the pregnant women population, there's been documented improvement of insulin metabolism. And in the postmenopausal women, there has been some goiterdogenic effects, but there's been beneficial effects on glycemic control and cardiovascular markers. There's been some benefits in the men population, as well as some alterations in children. But ultimately, the evidence of the effect of these phytoestrogens on the endocrine biomarkers is inconclusive. Now, kind of shifting over to the plant-based diets. The plant-based diet is essentially the idea that you're primarily consuming plants, although there are subcategories within that. Some consume only plant-derived foods, other add milk or eggs or cheese, other will add some fish. And so there is kind of a spectrum within the world of the plant-based diet. What we have seen is that there are large prospective cohort studies showing that the vegetarian diets show lower all-cause mortality, improvement in cardiovascular related mortality, and less cardiometabolic risk than meat eaters. There may be a reduction of risk of coronary heart disease as well as cerebral vascular disease. Lots of benefits to being on a primarily plant-based diet. So the Adventist Health Study was an interesting study in that it studied the Seventh-day Adventist Church. So this is a religious group that promotes vegetarianism. And in this study, they had a prospective evaluation conducted within the church members, and it started in 2002, and over 41,000 participants were included. And these individuals were without diabetes at baseline. Their goal was to detect the development of diabetes in the different subcategories of plant-based diets. And of the different vegetarian subcategories, the vegan patient showed the greatest risk reduction, and they had a 77% risk reduction in developing diabetes. Now, the lifestyle heart trial was actually a very exciting randomized controlled study published in 1990. And here what they did is they randomized patients into either an experimental group or to a usual care group. So to be more specific, the experimental group included a low-fat vegetarian diet, moderate aerobic exercise, stress management, smoking cessation, and group support. So kind of like the ideal approach to tackling lifestyle modification. And the usual care group was just a control group. And what they demonstrated was actual regression of coronary atherosclerosis within that experimental group. At 1 year, the experimental group showed significant diameter stenosis regression of atherosclerosis, while in the control group, there was actual progression of stenosis. Now, they then took this trial and extended it for an additional 4 years. So 35 of the original 48 patients continued on for a total of 5 years. And their primary endpoint demonstrated a % diameter stenosis reduction. So with continued experimental group lifestyle modification, the coronary patency improved significantly. But in the control group, they did show more progression of stenosis. So this is probably one of the only dietary interventions, a complete vegetarian diet, that actually has been demonstrated to show regression of atherosclerosis. So to summarize, I'm an endocrinologist, and I know that among myself and all other providers in our life today, unfortunately, obesity is really very prevalent and very much contributing to the forefront of the metabolic syndrome. And we know that dietary intervention is key. Weight loss is key to potentially prevention of coronary artery disease, regression of coronary artery disease. And these problems are very prevalent in the postmenopausal woman. And I invite Danette to continue on with the rest of the presentation. Thank you for having me.
Thank you, Dr. Gorodeski Baskin. That was great. Excuse me. So some of the things that I have in my slides are just kind of reinforces what Dr. Gorodeski said, and then obviously I have some other information as well. But cardiovascular disease risk, as was already said, is the leading cause of death for women worldwide. And most cardiovascular disease in women occur after 55 years old, which is during postmenopause for most women. And what studies have also shown is there's been other established risk factors for women, such as premature, early, and surgical menopause. There are also established risk factors for cardiovascular disease. Next slide, please. So the Life Simple 7 score, the American Heart Association, this is their predictors of heart health, which is also a pathway for achieving ideal cardiovascular health. So you can see there's 4 modifiable risk factors of smoking cessation, healthier eating, more physical activity, and losing weight. These 4, which we have talked about many times in Cardio Ohio. And then there's the 3 biometric measures: managing blood pressure, controlling cholesterol, and number 7 should say reduce blood sugar. So these behaviors and measures, what the American Heart Association did, they classify them into 3 categories of ideal, immediate, and poor. And just as an example, for smoking, currently smoking falls into the poor category, which I don't think is a surprise. A former smoker who stopped smoking, well, let's say within the last year or so, would be intermediate. And then someone who never smoked would be in the ideal category. But there's a nice, there's a website, below that if you click on that, it will give you, all of the categories and what they mean. Next slide, please. So some traditional risk factors for women for atherosclerotic cardiovascular disease risk includes diabetes, smoking, excess weight, physical inactivity, hypertension, and dyslipidemia. Next slide, please. Some emerging non-traditional risk factors for women include preterm delivery, hypertensive disorders of pregnancy, gestational diabetes, breast cancer treatment, autoimmune disease, and depression. Next slide, please. So what I find kind of interesting about this article that was published in 2020 is a scientific statement from the American Heart Association. As it talks about cardiovascular disease risks that are specific to the menopause transition. And we know we have Life Simple 7, we have the traditional and the emerging non-traditional cardiovascular disease risk factors. But there are also characteristics related to the menopause transition that amplifies cardiovascular disease risk for this population that, in my own personal opinion, I don't think we should ignore. Next slide, please. So these characteristics that were pointed out in the publication in the previous slide include age at natural menopause, natural versus surgical menopause, stage of reproductive aging, so pre, peri, and post, endogenous estrogens, which are just estrogens that we naturally make in our bodies, hot flashes and night sweats, which are also referred to as vasomotor symptoms, problems related to sleep disturbance, depression, cardiometabolic health, and weight gain. And I'm just going to just give a very brief overview of each of these characteristics. Next slide, please. So starting with age and natural menopause, what studies have shown is that early onset menopause, which is defined as menopause younger than 45. So these women are at a significantly higher risk for cardiovascular disease, heart failure, and fatal coronary heart disease compared to women who experience menopause after or at age 45, even after adjusting for traditional CVD risk factors. Studies have also shown that natural menopause experienced between 50 and 54 compared to younger than 50. They have a lower relative risk for cardiovascular disease, but there's also some evidence, as we know in our literature, there's, normally evidence for or against, but there's more evidence about early onset menopause and risk. But there's also some evidence to support a reverse association that later onset menopause, which is defined as 55 or older, is related to cardiovascular mortality. Next slide, please. So surgical induced menopause, and I can say that, I see several women in this category, even coming through being evaluated for bariatric surgery evaluation or weight management. And this is when a woman has her ovaries removed, either surgically removed, either, both or one. But it puts women at a higher risk for coronary heart disease with no estrogen hormone therapy compared to natural menopause. And other study shows that surgically induced menopause that's performed close to the age of natural menopause, expected menopause, and that age is 51 years old. So these studies show that there's small to no association between surgical menopause and coronary heart disease risk, but coronary heart disease risk is higher if surgical menopause is performed younger, or let's say younger than 40 to 45 years old. So surgical menopause, and this was stated earlier by Dr. Gorodeski Baskin about, our hormone levels, but there's an abrupt non-reversal drop in hormones such as estrogen, progesterone, and androgens. And with early menopause, I think, one of the biggest problems that has been shown in studies and in the literature is that women are at risk for long-term effects of early estrogen deficiency compared to women who experience menopause later in their life. So with stages of reproductive aging, which is pre, peri, and post, studies show that there appears to be an accelerated increase in LDL-C and total cholesterol, triglycerides, HDL-C during the year immediately after the final menstrual period. Whereas glycated hemoglobin A1C and blood pressure appear to maintain their usual trajectories during this transitional period. So over the menopause transition, there are also alterations in endogenous hormones, again, hormones that we produce naturally in our bodies. And particularly there's a big drop and sometimes a lot of hormone fluctuations during the menopause transition, which causes, hot flashes, mood changes, and things like that. But then there's even more of a drop after postmenopause. And then that creates or causes a lot of cardiovascular risk factors and other medical problems. Next slide, please. So because estrogen significantly declines during this menopause transition and postmenopause, that decline has been, I think I already said, associated with the number of cardiovascular disease risk factor changes. And studies also show that after menopause, blood flow in all vascular beds also decrease. Next slide, please. However, there are studies such as the SWAN study that shows that participants are likely to develop carotid plaque if they have higher estradiol before their final menstrual period, but lower estradiol afterwards were less likely to develop carotid plaque post-menopause. So a little bit different here. So going into vasomotor symptoms, studies show that vasomotor symptoms or hot flashes and night sweats during the midlife years are linked to adverse lipid profiles, insulin resistance, and a greater risk for incident hypertension. And studies that compare women with and without menopause symptoms show that vasomotor symptoms are associated with an increased risk of cardiovascular disease, coronary heart disease, and stroke. And there's a higher carotid intima media thickness for women with hot flashes, and also women with hot flashes and excessive weight, that it increases the risk even more. And just to kind of say, you know, lower estrogen levels may cause a woman's heart and blood vessels to become stiffer and less elastic, and which can increase their blood pressure. It can damage their blood vessels and increase their risk for the stroke, heart disease, and heart failure. Next slide, please. So sleep disturbance, and as a psychologist, I do help women to improve the quality of their sleep using cognitive behavioral therapy for insomnia. And so there's studies that show that a shorter sleep duration, poor sleep quality, greater severity of insomnia are associated with worse scores in postmenopausal women compared to premenopausal women using the AHA Life Simple scores. Next slide, please. And just to kind of like add to the sleep, there's a study that actually just came out and was written up at the Menopause Society conference. This was conducted at, I believe it was Pittsburgh University or Penn University. Rebecca Thurston, her study showed that persistent insomnia or short duration of sleep or 5 hours or less also increased cardiovascular disease risk twofold, you know, compared to women who do not have problems with sleep. But regarding depression, it's also related to incident cardiovascular disease and vasomotor symptoms. And the occurrences of depression are more frequent during the perimenopausal and postmenopausal years. And there's so many reasons why depression increases for this population. I mean, we have things that, you know, like we're sandwich generation, you know, kids going to college and empty nesting, changes in hormone fluctuations in hormones that has led to depression. You know, and women who have a history of major depression tend to have more depressive episodes during this transition as well. And matter of fact, their depression symptoms may worsen and their anxiety symptoms may worsen as well. Next slide, please. So the SWAN heart study, and I want to kind of like emphasize this, SWAN studies of women across the nation. They have done several longitudinal studies with the focus being on menopause. But in the SWAN heart study, there was a 5-year follow-up in healthy women, and they showed that, you know, medically healthy women, they showed that having greater than or equal to 3 episodes of depression versus no episodes of depression were significantly associated with elevated coronary artery calcification scores. Next slide, please. And so some women's health initiative trials found that depression was an independent predictor of cardiovascular death and all-cause mortality for women with no history of cardiovascular disease after adjusting for established CVD risk factors and demographics. Next slide, please. So cardiometabolic health, longitudinal studies over the past 20 years showed that over the menopause transition, there's alteration in cardiometabolic and vascular health parameters linked to high CVD risk. There's adverse changes in lipids and lipoproteins, and metabolic syndrome has been found to increase with menopause, independent of age. And there was a beautiful slide that Gorodeski Baskin showing, about menopause syndrome and visceral adiposity. Next slide, please. So weight gain, there's changes in fat to lean mass in the menopause transition. And what I think is really significant here, personally, for me to point out, is that there's changes in the distribution of weight. So even if a woman doesn't gain weight or gain a few pounds, there's going to be a change, and there's going to be more weight centrally. And so the visceral fat increases, and also lean muscle mass can decrease. And the increase in central adiposity has been found to be associated with an increased risk of mortality, even for midlife women with a normal BMI. So independent of age, after menopause, pericardial fat volumes are higher after menopause, which could be influenced by estradiol levels. And postmenopausal women with a body mass index of greater than or equal to 40 and a waist circumference of, let's say, 45.35 to over 48 inches, compared to women with a waist circumference less than or equal to 34.65, were found to be associated with higher total mortality and incidence of heart failure and coronary heart disease. So postmenopausal women in the normal BMI range, and they're but with a waist circumference greater than 34.65, were at a higher risk of mortality compared to midlife women with a normal BMI and no central adiposity. So central adiposity, it really does increase the risk. It becomes a major factor. Next slide, please. So something that, if I had like one take home point from this, my portion of this presentation would be, should we be thinking of other factors in terms of like our evaluation and assessment of women who are peri or postmenopausal age? Because there's a lot of factors to consider that are not traditional. Some of these were pointed out in the emerging non-traditional risk factors. And then also with the menopause transition characteristics, depression is something that we cover quite frequently here at Cardi-Ohio. We're very consistent with that here. But some other things to consider in asking women, have you had your final menstrual period, and try to find out where are they in that transition, or have they even started? Have they had surgical induced menopause? And in terms of hormones, there's a lot of literature about hormone prescribing and menopause and how it's so under-prescribed. Should that be looked at more? Hot flashes and night sweats, we can help women control that. I know that there's like cognitive behavioral therapy that actually can help with that. And there's also problems related to sleep disturbance. So I guess what I am suggesting is that maybe we should kind of broaden the lens when we are assessing women in this population. Next slide, please. So age and race differences. So earlier age at natural menopause is a marker of greater risk for cardiovascular disease. Studies are inconsistent regarding race and ethnicity and timing of natural menopause, but studies have shown that Black, Hispanic, and Native Hawaiian women may experience menopause at an earlier age compared to non-Hispanic, white, or Japanese women. Next slide, please. And there's also studies that show that the knowledge about menopause and cardiovascular disease risk is higher in white women compared to Hispanic and African American women. So maybe as practitioners, we can do a better job educating women across all races and ethnicities. Next slide, please. So this study I found interesting because I'm drawn to something that has a more positive spin. And so this particular study focused on positive deviance versus negative deviance in African American and Hispanic women with a high risk for heart failure and looked at protective factors that delayed the onset of incident heart failure. So there were 11,327 African-American women with a mean age of 61 and 7,986 Hispanic women with a mean age of 60 who were enrolled from 1993 to 1998 and followed through 2018 for hospitalizations for heart failure. So positive deviance was defined as occurring when high-risk populations have unexpected positive outcomes rather than negative outcomes. So 27% of the African-American women in this study and 25% of Hispanics exhibited positive deviance over a 16-year follow-up. The positive social factors that were included in their analysis were optimism, social support, and religion, and the negative factors were living alone, social strain, and depressive symptoms. Now, unadjusted models showed that African-American women with one or more risk factors and a high genetic risk for incident heart failure hospitalization, the optimism was modestly associated with reduced risk, and social strain was associated with modestly increased risk for heart failure hospitalization, whereas unadjusted models showed that among Hispanic women with one or more risk factors and a high genetic risk of incident heart failure hospitalization, that living alone was modestly associated with increased risk of incident heart failure hospitalization. But in fully adjusted models, there was no associations with any of these factors, positive or negative. So they're just basically suggesting we need to do more studies and maybe include more of these psychosocial factors to understand better this positive deviance better. Next slide, please. So interventions, we've already saw great examples of interventions, dietary interventions. So lifestyle interventions are great, but other studies show that multidimensional lifestyle interventions can help women to not only prevent weight gain, but reduce triglycerides, blood pressure, blood glucose, and insulin. And multidimensional includes smoking cessation, physical activity, weight loss, DASH diet, all the things we normally talk about in Cardi-OH. Next slide, please. And I think this, I'm almost finished here. So studies found that initiating menopause hormone therapy less than 60 years of age or within 10 years of menopause reduces the risk of cardiovascular disease. Reasonable life interventions based on current data is to target ideal body weight with low central adiposity and maintenance of skeletal muscle mass. And the diet most recommended has been a Mediterranean diet, which we heard earlier is a lot of benefits, but lipid lowering interventions remain ambiguous. Next slide, please. Thank you very much.
Great. Thank you so much, Dr. Conklin and Dr. Gorodeski Baskin. We're going to open it up for questions for our speakers, for our presenters following their presentation. Are there questions or comments that anyone would like to make?
This is Paul. I've got one quick comment and then a question, if I may. I think we're all probably aware of the effect that the medications that people use can have an effect on the metabolic syndrome. I'm certain nobody eliminated that aspect for a good reason, but so many of the clients that we see here Southeast, and I suspect are seen in other locations, are taking the antipsychotic medication or the antidepressants or the mood stabilizers or what have you. Such a profound effect on the metabolic syndrome. So it's kind of a double-edged sword there. And my question is, Dr. Conklin, fascinating. I'm wondering, what does the literature show in terms of an effect that environmental factors or the social determinants of health have on early onset menopause? Is there a relationship there that can be addressed or can be acknowledged?
Oh, that's a great question. I would say I have not seen anything in the literature that it would cause early onset menopause, but it can increase the severity of the symptoms because of the stress. But what we have found is that social determinants of health, it really does play a big factor, like age, race, education, where a person lives in terms of how much knowledge they will be given by their practitioner, and if they will, their practitioner will even talk to them about menopause, or even if they will bring it up. So what we have found in the literature is that, for practitioners to pay closer attention to women of all races and ethnicities, ages, not assume that, one race doesn't need more information about menopause hormone therapy or menopause in and of itself compared to another. I hope I answered that sufficiently.
Yes, ma'am. Thank you.
And thank you for the question.
Okay, we have a question from Karen Bailey. Is MHT for premenopausal or early menopausal women standard practice or recommended?
Based on the knowledge that I have, for premenopausal women, I mean, you're probably on like birth control and whatnot, but for, I think you said, did you say post or peri? I'm sorry, what was it?
Premenopausal.
Oh,
or early menopausal.
Early menopausal, yes, and hormone therapy would be recommended. Dr. Gorodeski Baskin, do you have any other added information for that?
From my understanding, and I don't specifically take care of menopause, but it's recommended to be initiated in the first 5 years post, official start of menopause. So after that, it's a question mark, and obviously, with the risk factors and kind of digging into pros and cons, but it's encouraged earlier on. So yes.
Great. I just wanted to make a quick point. The Ornish Lifestyle Medicine program that you mentioned, Dr. Gorodeski, just wanted to let folks know that that is covered by Medicare. So there's a reversing heart disease program. I have a few patients that are in that program and they really love it. And they've made a successful transition to a plant-based diet. Now, my question too is that for either of you, the big challenge is the implementation aspect of transitioning more to a healthier diet, a higher quality diet, a plant-based diet. And what approaches, if any, do you recommend for helping women make that change, make that shift towards a plant-based diet?
So even though, true plant-based diet has been shown to be very beneficial for regression of coronary artery disease, I generally don't necessarily push patients into that specific category. I primarily focus on the Mediterranean diet and recommend that to be initiated because it is probably more realistic for most patients.
Mm-hmm.
And only once they really dig into being kind of in a generally healthier lifestyle will I encourage more of the plant-based approach. But I go patient by patient because I think it's very hard for patients. We are a very carnivore-driven society, and especially red meat. So I first encourage decreasing the red meat intake and then kind of slowly transition through that. Here at university hospitals, I have set up a program where I see patients in the setting of shared medical appointments, and I see them on a monthly basis. And it gives them a sense of accountability and camaraderie. We have a registered dietitian that they see as well, and of course, pharmacological intervention for the anti-obesity medications, if possible, and covered by insurance, and if they want. But the main focus is essentially the Mediterranean diet / DASH diet and lifestyle modification and encouraging strength training exercises, seeing an exercise physiologist if necessary, and so forth.
Yeah, I'm sorry, by plant-based diet, I meant just shifting in that direction towards Mediterranean or different variations of a more plant-based diet. Okay, great. So Andy, we'll turn it over to you.
For some quick reminders, you can find all past and present Echo clinics on our cardio website. Next slide. And then just as a reminder, you should have a post-clinic survey in your inbox from earlier. Please complete that by Friday. And then please let me know if you have any questions. I did send out the final case study schedule for the rest of the clinic. So let me know ASAP if you can't present on that day. Otherwise, thank you so much.
Have a good day, everyone. Take care. Bye-bye.